Hi, everybody. I started to receive a few questions after that first post, so I thought I would come online here and see if there's any questions that people have out there. As let's be honest, on this Easter Sunday with social distancing, there's certainly not a lot of things that are going on right now, and if I can be of help in offering up any thoughts, I can certainly see if I can help a few people. These are troubling times for sure, and I would like to, of course, mention before we really get started on taking perhaps a few questions that I am speaking only for myself. This in no way is reflective of any of the opinions of anyone within the government of Manitoba or within Children's Hospital or Shared Health for that matter. And so having written the CPS practice points, if there's anything that we can help with, again, during some challenging times, this would certainly be the time. One of the questions that I did get, and I'm just going to pull it up here from the last post, had to do, excuse me, with, I think, separating mums and babies, which is something that I know is troubling for a lot of people right now. So I'm just going to pull up the post here. One of the questions was, can new parents be forced to distance from newborns in Ontario? Huge implications for attachment, nursing longevity, and parental human rights if it's true. Somebody actually asked me this question as well, or it wasn't so much a question as it was a comment on Twitter earlier today about the legality of saying that we have the right to separate parents and their babies. There's no question, is a very difficult thing for families to get their head around. I would say it's very difficult for all of us to get our head around. But at the end of the day, I don't know that, what would happen in a legal challenge, so I can't speak legally. But as far as keeping everybody safe, I think we have to look at a couple of things, and I think this was outlined in the CPS practice point. One of the things we have to look at is the difference between postpartum care in a postpartum ward and care within the NICU. So the postpartum is a bit easier because if the newborn is well, I can't speak to what's happening in jurisdictions across the country, but I can say that if the newborn is well, I don't really know if there's any need for separation of mom and baby. There's not in my mind any need to interrupt the bonding that would take place between mom and the father or the partner for the infant. So I would say that in those cases it makes sense to me that one could isolate mom and baby and the partner in a postpartum room, and for those situations I don't think we need to look at separation. When you're talking though about the NICU, that's a different kettle of fish. In the NICU we have many infants who are extremely vulnerable. We don't yet know, other than a report that I did see out of Israel, at least in the lay press, of a premature infant who had BPD that wound up getting COVID-19. But again, nothing in the literature to suggest yet what the impact would be on those sorts of infants. But because of that, personally, I don't want to know what the impact is on those sorts of infants. I think that it's very important that we not test those waters if we can, and so in order to prevent that from happening, I think the best thing that we can do is to try and limit exposure of COVID positive parents in the NICU. We're really asking for parents' understanding and trying to limit the potential spread. That's sort of what I have to say about that. Is this is certainly an evolution. I just got a question. I'm having to use both two sources here. I've got an iPhone and I've got my iPad here. So one of the questions that I think I just got had to do with swabbing. Oh, sorry. We are.
My iPad here.
Sorry.
So one of the
You're
questions
swabbing at 3 days of age. Say we are only swabbing on day 3 of symptoms due to false negatives. So I think, I'm glad somebody mentioned, Melanie, thank you for your comment. I'm glad you mentioned the question about false negatives. I think that there may be some misinformation out there in the community. There was a news story that broke, I think, a few weeks ago about a 30% rate of false negative testing. And this led to a lot of people questioning, oh, my goodness, what are we doing? How do we know that a negative is a negative? But I think when you look at it, a little more carefully, what you discover is the false negative rate is such when you have, an asymptomatic newborn. So if you're simply taking a well newborn with no symptoms and you're doing a nasopharyngeal aspirate, there may be up to a 30% chance that test will come back negative, because you need the secretions in order to test them. So if you do a nasopharyngeal aspirate and there's essentially no secretions because they're the baby's not having symptoms, you may get a negative when in fact the baby has been infected but is not yet manifesting symptoms. When you do a swab on day 3, I think it's important to realize, I'm not suggesting for a moment that it's all for naught. A swab on day 3 could be informative, because that will tell you if it comes back positive that the baby may be infected. But what it doesn't do by the time day 3 comes around is tell you whether or not the baby has in fact acquired that infection in utero. So I wouldn't say that it's a waste of time to test at 3 days of age, and in fact our general approach would be to test at 3 days of age, at any point when the baby develops symptoms. But if we knew a mother was COVID-19 positive, we would actually swab them between 1 to 2 hours of age, and what we'd be looking for there is a positive to document vertical transmission. Of note, if you're going to do that approach, it's so important to to wash the face, clean the face off before you do the nasopharyngeal aspirate, because we don't want to risk having secretions which may have virus in them contaminate the face. Having said that point, for those of you who have read through the practice point, you would know that there is a comment in there about vaginal secretions testing negative. Curiously, I don't know if anyone has looked at that paper that was based on, but that was from 10 postmenopausal women who had their secretions tested. All of them had severe COVID-19 pneumonia, and they were negative. Would that still hold true in pregnancy? I would hope so, but it is worth noting that it wasn't pregnant women that were tested with that. So I'm just going to scroll through here. I think that may be so far all the questions I have, but I'll see if there's any others that have popped up. Just one moment here. Yeah, I think so far that may be the only question. I'll just ask if there's any others. And Melanie, I hope that answered your question, and that this was somewhat helpful. So aside from that, I also thought it would be worth mentioning that for those of you who saw the CPS practice points on April the 6th that were released, I'm not sure if everyone is aware that the CPS practice points are being updated, and they were last updated, I believe, on the 9th of April, and we will be every week looking for new evidence out there and updating those practice points as new evidence becomes available. There is a couple more questions just came up. One is thoughts. I believe this is Lara has asked the question if there's any new thoughts on vertical transmission. So Lara, the only thing I can tell you is we have recently seen a paper that came out of New York City that looked at The first U.S. experience, and I posted that recently on All Things Neonatal, there was a report of, I believe, 43 pregnant mothers, and I believe, it's escaping me right now, but I think there may have been 18 babies that were born to mothers who had come in. And so of those 18 babies, all of them tested negative for COVID-19. So as I mentioned in my first Facebook Live post a little while ago, it's a little unclear, what to make of some of these news stories that are coming out, or tweets that you see on Twitter of people claiming that they've seen positives in newborns, because if they're not in the literature, it's hard for us to comment on them. So that's where we're at with vertical transmission. As far as we know, it still doesn't exist. But certainly early horizontal transmission is definitely a possibility. So thank you for that question. Another question that's just come is, what are your visiting policies at present regarding parents in the unit? Thank you for that question. That's from Kate Ann. The current visiting policy is that if you are COVID positive or you are COVID suspect, we are not having people visit until they are either cleared or IP&C clears them once, if they are indeed positive, and allows them to come back. We talked about that a little earlier. Very difficult. There's no doubt it's very difficult on so many families. Certainly there's going to be a lot of need for support for families as they go through this, because let's be honest, when you have a newborn, the very first thing you want to do is be with them 24/7. And so that's a real problem. It's a real problem, and perhaps telehealth can help with that. Hopefully, units will engage if you don't already have telehealth, but I think it would be wise to try to get video conferencing, televisitation in place. Another question that just came up is, should we treat all mothers as if they are positive and wearing PPE? And that's from Laura. Thank you, Laura, for your question. This is, I think going to vary by jurisdiction. If you have, certainly a high burden of illness in your community, I can say that I believe many places on the obstetrical side are now treating everyone who walks through the door as possibly COVID positive. One of the issues there is we do know that there are some asymptomatic people who are infectious who have not yet manifested symptoms. So to err on the side of caution would be to have everybody use PPE. Now, as far as mothers wearing PPE, that is something that people are still working through. The PPE that we have certainly protects us, the healthcare provider. Should the mothers be wearing their own PPE? Certainly, if they are COVID positive to protect their newborn, they should be. But if they are simply visiting and we don't yet know that they're positive, that is something that people are still working through. Dr. Ahmed has asked, is it true that COVID-19 infects RBCs and interferes with protoporphyrin? Dr. Ahmed, I've not heard of that. I would have to research that and get back to you, and I'll certainly have a look after we get off and see if I can find anything, and I'll post if I can find something. But that would be the first I've heard of that. Destiny Reeves, what are you doing for breastfeeding in a case of positive or suspect mother? That one I would refer you, we'll talk about it, but I would refer you to the Canadian Pediatric Society. That's www.cps.ca, and look at our practice point on that. We are certainly suggesting that this should be a shared decision with healthcare providers and mothers, looking at whether they think that this is something that they would like to do, using precautions, of course. The precautions that we would recommend if mom is COVID positive are to wear a mask, have a gown, wear gloves, wash their hands frequently, and wash their chest with soap and water prior to having baby latch on. For mothers who opt not to breastfeed, the other option is pumping. And if a mother is not going to be if a mother's COVID positive and has to be at home, we strongly encourage them to pump. first having cleaned their chest again and all the equipment to make sure that they don't transmit that into the breast milk. And then policies and procedures need to be put in place in order for people to get milk transported to the hospital in a safe manner. So getting somebody to come and pick it up and having steps in place to ensure that that person who comes in to get the milk, perhaps on the doorstep, now that the weather's warming up a little, doesn't themselves get infected. So certainly, Destiny, it is very possible to have people breastfeed. And that's something that we at the Canadian Pediatric Society are certainly in line with. Ramya, I hope I'm pronouncing that properly. What are your practices, policies been regarding two-person caregiving during all of this? There is a concern about inability. Sorry, I can't see the rest of this. So we, I can't really tell you much about that question. I'm sorry. I mean, we don't, to my knowledge, have a two-person caregiving policy. One of the things that I can say is many units have banned visitation altogether, certainly in the adult world. In the neonatal world, people may be allowing one parent to come. We certainly are not having two at the moment. And so that's just the reality of today. Mark, nice to have you on. So Mark's question is, can you please talk about your NICU's intubation plans, i.e. filter on a JR bag, limiting number of staff in the room? So this again is another hot topic about how do you prepare for intubation. I am aware there are filters that can be placed in line on a JR bag. I don't believe we have talked about using them yet, although I think that is a very good idea in the NICU. If you've read the CPS statements or practice points, you would know that I am not a fan of using these precautions in the delivery room. As I and others tend to believe that the evidence is not in favor of aerosolization in the delivery suite being a significant issue. One of the things that I think is worth considering, and there's been a lot of chat about this, is what to do with neonates who typically we don't use cuff tubes. And when you don't use a cuff tube, there's often a leak around that endotracheal tube. And if there's a leak, I'm not clear whether a filter is going to help very much, whether it's on your JR bag, in between the JR bag and the endotracheal tube, or at some point on the expiratory and inspiratory limbs of your ventilator circuit. If you have a leak, I think you're still going to see leaking into the air. But you touch on a very important point, which is limiting the number of people that are in the room. I think that if we can, minimize the number of people that are at the bedside doing the intubation, that is probably the best advice that we can offer. Is let's put the fewest number of people at risk as possible. Having said that, there's also been some interesting discussion out there about the use of video laryngoscopy. Not that I will demonstrate this on Facebook Live, but with video laryngoscopy, you don't necessarily need to be right in the face of the infant. You're able to stand back, look at a video screen, and do the laryngoscopy separately. And so if there was ever a time for video laryngoscopy, now might be the time. And so that's something to certainly consider. Another question has come up. Do you think all pregnant women should be tested, even though we know some of them could have a false negative result? Thank you for your question, Sandra. That is a hot question out there. I think that some places are beginning to test all pregnant women. I don't know if that's necessary. I think that there's two options that I think you can go with here. One of them is you can test them all, recognizing that if you have asymptomatic mothers, you may have a 30% false negative rate. So the point there is that may cause more harm than good, because if you get a negative result, you might think that the mother is, of course, not infected, and you might loosen some of the caution that you would otherwise have. So if you take just a universal approach and assume that they're all positive and use proper PPE for all of them, and when I say proper PPE, I would like to point out that doesn't mean an N95 mask if they're not intubated, but it does mean using gowns, gloves, masks, and so forth, so enhanced droplet precaution. So I think that's probably the better model to go with, because again, I worry about false negatives leading to a loosening of practice. Newman just asked a question. Thank you. Do you use cuffed endotracheal tubes routinely during NRP? So Newman, we don't use cuffed endotracheal tubes. One of the problems with a cuffed endotracheal tube, certainly for if it's a 2.5 or a 3.0 endotracheal tube, the internal diameter of those tubes is very small. And so what winds up happening is you may actually help yourself in one way in that you're limiting the amount of expiratory virus that potentially is there. However, ventilating that patient is going to be very difficult. And I think at the end of the day, we all have to remember something that's very important. These babies need resuscitation. To me, the virus is secondary. The most important thing we need to keep in mind is no matter what, we have an obligation to resuscitate these infants and resuscitate them well. And so ventilation, as you know from NRP, is one of the most important things we do. It's, if not the most important thing you do in the newborn period to get a baby resuscitated. And so I would worry about using cuffed endotracheal tubes in the resuscitation room, in the delivery room in particular, given the thoughts on likelihood of transmission in the delivery suite. So aside from that, I think I'm going to call it for a day here, and just thank everybody again for tuning in. I just saw there's been people tuning in from New Zealand, people tuning in from South Africa, and that's great. And I hope that this has been useful. If you're looking to see some of my thoughts on things, you can always go to www.allthingsneonatal.com. On Twitter, I can be found at NICU_musings. And on Facebook, you obviously know where to find me. And Destiny, I see that you're from North Dakota. You're a neighbor, and it's nice to see you tune in. And wow, very interesting. Thank you everybody for telling me where you're from. This is quite incredible. There's Australia and Scotland and Baghdad. New Zealand. Yeah, this is very, very incredible, this technology. I'll try to use this again in the future. I really hope that everybody out there is staying safe. I want everybody to have a great Easter weekend. Be with your family, hug your family, and love those around you, and stay safe. Take care, everybody.